Hypertensive crisis is defined as a rapid and severe increase in blood pressure, usually with a systolic of greater than equal to 180 and diastolic of greater than equal to 120 millimeters of mercury, or one of them, and it is associated with 1 to 2% of all hypertensive patients. It has a number of causes. A well-known cause is somebody having essential hypertension and does not take medications for control. This leads to a hypertensive crisis. Also, medications such as non-steroidal anti-inflammatory drugs, antidepressants, and even withdrawal from some antihypertensive medications can cause a hypertensive crisis. Other causes of secondary hypertension, such as in pregnancy, preeclampsia or eclampsia, is a well-known cause of hypertensive crisis. Also, renal diseases and endocrine diseases such as pheochromocytoma. There are two types of hypertensive crisis. First, hypertensive urgency. Here the patient usually presents with anxiety, dyspnea from acute pulmonary edema, mild headaches usually, and even epistaxis. Here there is no end organ damage, and by definition the blood pressure is usually greater than 180 on 120 millimeters of mercury. Hypertensive emergency is another type where there is end organ damage. The organs involved here are the brain, the heart, and even the kidneys. In the brain, it causes intracerebral or subarachnoid hemorrhages, cerebral infarction, or hypertensive encephalopathy. In the heart, it causes acute coronary syndrome, aortic dissection, or acute heart failure. In the kidneys, it causes acute kidney injury. It's worth noting that malignant hypertension, also known as accelerated hypertension, is a hypertensive crisis that is associated with retinopathy, usually grade 3 or 4 retinopathy, that is blood hemorrhage or papilledema. It's associated with a diastolic of 130 millimeters of mercury. Usually there is rapidly progressive malignant nephrosclerosis in the kidney, left ventricular hypertrophy in the heart, and cerebral dysfunction. Here, due to the excess pressure in the arterioles and small arteries, there is microangiopathic hemolytic anemia, and there is leakage of plasma into the tunica media with consequent deposition of fibrin, leading to a process called fibrinoid necrosis. For the diagnosis, we need the medical history. We need to know how long the patient has been hypertensive. We need to know the antihypertensive drug therapy and the over-the-counter drugs such as cocaine and amphetamine the patient is taking. We also need a clear picture of the symptoms such as anxiety, dyspnea, epistaxis, mild headaches, which occur in hypertensive urgency, and hypertensive emergency symptoms such as dyspnea due to left heart failure, chest pain in acute coronary syndrome, anuria or oliguria, hematuria in the kidneys, facial deviation, hemiparesis, confusion, or even seizures in the nervous system. A neurological exam should be done. Fundoscopy to identify retinopathy should also be done. A cardiovascular exam should also be done where a raised jugular venous pressure can be identified, for example. For the investigations, blood can be collected and viewed under microscope for fragmented red blood cells, serum urea, creatinine, urinalysis, serum electrolytes for kidney injury, an ECG for cardiac problems, a cerebral CT scan for brain pathologies. A chest X-ray can also reveal pulmonary congestion. Now the treatment. The aims of our treatment here is first to break the cycle of increasing systemic vascular resistance and blood pressure. Secondly is to prevent or limit the target organ damage. and thirdly is to treat the cause of the crisis. The problem is how low and how fast we are to drop the blood pressure. For example, we have to lower the blood pressure within 24 to 48 hours to less than 160 on 110 millimeters of mercury for hypertensive urgency. Usually, the doctor will prescribe bed rest on arrival at the hospital and observe the patient for an hour, then assess the blood pressure after 30 minutes of bed rest. Then if the blood pressure is still in the hypertensive urgency range, we prescribe oral antihypertensives. In our case, we use nicardipine 20 milligrams, one tablet 3 times a day. But all other classes can be used except rapidly acting oral calcium channel blockers and loop diuretics unless pulmonary edema. Then we are also supposed to monitor the blood pressure every 4 to 6 hours. For hypertensive emergency, the management is done in the intensive care unit, and here the target is to reduce the mean arterial blood pressure by no more than 25% within 1 hour, and then to 160 on 110 millimeters of mercury within 2 to 6 hours, and finally a further reduction to 140 on 90 millimeters of mercury within 24 to 48 hours. In this case, we use intravenous antihypertensives. For example, with the Luxent protocol, nicardipine intravenous is used, 5 ampoules in 250 milliliters of glucose solution to flow over 30 minutes, that is 10 drops per minute, and the flow rate should be increased by 5 drops per minute after every 5 minutes, and a maximum flow rate of 30 drops per minute should not be exceeded. We also need to monitor the blood pressure after every 10 minutes, and when the blood pressure is within the target range, we relate to nicardipine.